Hello, dear friends. Welcome to the webinar on liver health in pregnancy, organized by the Hepatobiliopancreatology Foundation and Eurasian Gastroenterology Association. I am Dr. Yasemin Balaban from Hacettepe University, Faculty of Medicine, Department of Gastroenterology. Before beginning the webinar, I wish a healthy and prosperous year for all of you. I will be moderating this webinar together with my dear colleague from Hacettepe University, Unit of Perinatology, Dr. Professor Özgür Deren. Dr. Deren, would you like to say welcome to friends?
Yes, good evening, everyone. It's a great pleasure to be part of today's webinar held by Hepatobiliopancreatology Foundation and Euroasia Association on liver health in pregnancy, a topic that holds significant importance in both gastroenterology and maternal fetal medicine. As we know, pregnancy is a unique physiological state that can bring out latent liver conditions or even cause new liver disorders. And these conditions can have serious implications both for the mother and the baby if not diagnosed and managed properly. And maternal fetal medicine focus on the complex interplay between maternal health and fetal being, and also the collaboration between hepatologists, gastroenterologists, obstetricians, and maternal medicine specialists is more important than ever, especially when dealing with these diseases. So I hope today's webinar will shed light on these critical conditions and provide evidence-based approaches for diagnosis and management, as well as ensuring safe maternal and fetal outcomes. And today's webinar, our esteemed speakers will be sharing valuable insights with you. Welcome again, and I hope you will have a good webinar.
Thank you, Dr. Deren. Before I introduce esteemed Professor Norah, I would like to express my deep sorry about the ongoing fire disaster in Los Angeles. I pray for soon controlling the fire without any more life loss. Thank you, Norah, for coming. Dr. Norah is the past president of AASLD and current member of AASLD Executive Board. She was leading author of the AASLD 2020 Clinical Practice Guideline on Reproductive Health and Liver Disease. Among all others, she has recently received EASL's 2024 International Recognition Awards. Dr. Norah is the chief of the Gastroenterology and Hepatology at Medical Center of University of Southern California in Los Angeles, and she serves as associated editor of the Hepatology and the current associated editor of the Hepatology Communication. She is recognized internationally for her work related to viral hepatitis, especially in the setting of liver transplantation. She has authorized more than 290 articles, reviews, and book chapters on viral hepatitis. She has directed several NIH-funded clinical trials in hepatitis B, C, and as well as MASH. She is investigator of several ongoing clinical trials of novel therapies in patients with chronic hepatitis. Thank you, Norah, for coming. We will be so happy to listen you.
Thank you. So first of all, I am absolutely delighted to be here. Thank you for your very lovely words and wishes for all of those of us living in Los Angeles. So we're all hopeful the fires will be over soon. But I really want to thank you for organizing this symposia. I'm excited to be part of it, and I'm looking forward to the discussion this morning. So, okay, now I'm trying to share my screen. You'll tell me if I'm successful. It seems it's preparing my slides. Can you all see my slides? Oops, sorry.
Currently not.
Okay.
I can see them, Norah.
Oh, you can? Okay.
I can,
Okay.
yeah. I don't know if it's just me, but I can.
Okay. Let me just change the view here. Let me just say. I'm trying to change it to the presenter view. Just give me 1 second. I practiced beforehand. One second. View. Should I try resharing if you all can't see them? Can you see them now? Yes?
No.
No?
No.
Debbie, can you see them?
Actually,
Yeah, I can. I can.
but
Okay.
somebody cannot see. I don't understand the reason.
Okay.
I'm-
Should I
So
start?
did you share your slides on the screen?
Yes. It says share. It says sharing at the top.
Then, okay,
Yes.
moved already.
Can you see it now?
Yes, I can.
Okay.
Yasemin, can you see?
Unfortunately,
Yep.
I cannot.
Me too.
All right. Let me see. Share. I don't know what to hit here to make it happen.
I don't know, because you're in the presenter view.
I am in the presenter view. That's
Yeah,
why
you
I'm
are.
not sure what else I can do.
I can see it, yeah.
I'm wondering why you can see it and others cannot.
I don't know.
Very unusual. Do you have some suggestions on what I might do?
Let me ask anyway somebody to correct it.
How about now? Anybody? Can you see it?
Yeah, I can still see them. They haven't moved. It's titled Reproductive Health, and it's
Yeah.
I can see it. It's 33 slides, isn't it? One of 33. Yeah.
Yeah, that's exactly right.
Hmm.
Okay, well, do you want me to stop sharing and try again? What do you suggest?
I think
Okay, so
try
most
again,
people can't
please.
see it. Okay, some people can, some people can't. So I don't know what's going on. Okay, let me try again. I'll try sharing. Let's try again. I'm sorry. I'm not sure what I'm doing wrong here after my practice session. Okay.
Slide'ı ben görüyorum, diğerleri görmüyor. Nasıl iş bu, Burak?
Okay, let me try one more time.
Niye? Peki sebep ne? Bunu nasıl çözeriz peki?
Okay, how about, let's see what's happening.
Norah, I spoke with Mr. Kubilay. He's the organizer for technical part. He said sometimes when we use Apple, this type of problem arises. So they are trying to solve. But I don't know what to do, whether we should keep going
well, maybe,
or wait for a while.
so that you can't see, I just started again. You can't see them?
No, I cannot. Maybe we can start with Debbie
I think
while
that's a great idea.
solving this technical issue. Debbie,
Let
would
me
you
try
mind?
then. But I've got an
Okay.
Apple computer too, so now I'm wondering if it's me as well. Let me go, because I've got an Apple computer.
Now I can see Debbie's slides.
Yeah,
Yes,
we
I
can.
You can?
We can. Yes, we can. We
Oh,
can
that's
see.
good. So I don't know what's gone wrong here. Okay.
They said it's most probably because of Norah's computers, some adjustments, let me say. So they are trying to solve it. So shall I introduce you, Debbie?
Okay, yes, that's fine.
And Professor Debbie Shawcross is another esteemed professor. She is a Vice Secretary General of the EASL, and she was awarded by Higher Education Funding Council for England Clinical Senior Fellowship in 2008. Professor Debbie is a clinical scientist and professor of hepatology at the Institute of Liver Studies and James Black Center of King's College in London. She works as a consultant hepatologist on the King's Liver Unit. And her special interests are hepatic encephalopathy, liver failure syndromes, and complications of cirrhosis. She is an advocate for high quality education and training in gastroenterology and hepatology, having been director of health education England London Gastroenterology Training Program for 10 years. She is an active member of British Society of Gastroenterology, supporting the women in gastroenterology, and she is also chair the British Society of Gastroenterology Research Committee. Her research area is immunology of the chronic liver failure, focusing especially on gut-liver-brain axis in context of gut microbiota. As a driver of immune dysfunction, inflammation, and encephalopathy, she is leading field in clinical trials of fecal microbiota transplantation, and she's directing a clinical trial supported by NIHR on the patients with metabolic associated and alcohol related cirrhosis. So welcome, Debbie. We are so eager to listen to you. Sorry.
Thank you very much. Thank you for the wonderful welcome. It's lovely to be with you. It's this afternoon for me in the UK. I know it's in the morning with Norah. So what I'm going to do is, I think Norah and I decided that we were going to split up the what we do so that we avoid overlap. And I'm going to take the first half of things. And what I'm going to try to do is to cover jointly the information on liver health in pregnancy that both the AASLD published back in certainly online in 2020, I think in print in 21, and then what we did at EASL, our clinical practice guidelines on the management of liver disease in pregnancy in 2023. So hopefully we're all singing from the same hymn sheet, and hopefully we've got really the same messages, and I'll try to incorporate both. I don't have any disclosures for this talk that are relevant. And for my half of the talk today, what I'm going to do is cover the management of cirrhosis in patients with and without portal hypertension in pregnancy. So that will be the first half. And then the second half of what I will cover is gestational specific liver diseases. So what I'm going to try to do is cover preeclampsia and the HELP syndrome, acute fatty liver of pregnancy, and pregnancy-induced intrahepatic cholestasis, which are huge areas in themselves. So I'm going to have to do a fairly quick overview, but hopefully I'll be able to share with you the most important parts. So if I start with talking about cirrhosis and portal hypertension, of course, this is extremely relevant because not only are we seeing increased rates of cirrhosis around the world, but actually also we're seeing more and more ladies who are pregnant with cirrhosis. And I think all of our single centre and population-based studies now are showing that year on year, more ladies with cirrhosis are getting pregnant. And therefore, it's very relevant that we think about all the things that are important when managing these people. But the good news is that actually maternal mortality is actually reduced significantly. And if you look at an original case series that was published back in 1982, maternal mortality if you had cirrhosis and you were pregnant was roughly 14%. And I'm pleased to say now that it's less than 2% in most of the recently published series. So with careful assessment and stratification and management, it's possible to actually plan and optimize a pregnancy and to have a good outcome. And live birth rates now, certainly the range is between 58 and 100%. But as I say, each year on year, it's improving. And neonatal rates, thankfully, are extremely low now, as are stillbirth rates. So hopefully, with good management, we can get really good outcomes. But of course, there are physiological changes that do occur in somebody who is cirrhotic, who is also pregnant. And actually, I've used the beautiful figure from the AASLD guideline here, just to hopefully demonstrate to you all of the important changes that happen in a lady with cirrhosis that actually increase portal hypertension. So with increasing gestational age, of course, you get dramatic physiological changes. You get increasing blood volume, splanchnic vasodilatation. That, of course, actually exemplifies what you've already got in a cirrhotic patient, which is reduced systemic vascular resistance and blood pressure. And in pregnancy, you get an increase in the portal flow, inflow, and intrahepatic resistance. And of course, also collateralization increases. And towards the end of the pregnancy, certainly in the second and third trimester, you also get compression by the fetus on the inferior vena cava, which further increases pressure. So all of this increases the likelihood that someone with cirrhosis is likely to bleed, but also to develop other decompensating events like ascites and hepatic encephalopathy. And a recent large registry study reported that pregnancies in women with cirrhosis are independently associated with the need for induction of labour, increased risk of puerperal infections, of course, preterm delivery, large for gestation age infants, and that's probably because there's a higher rate also of diabetes in many patients with cirrhosis, and of course there's higher rates of neonatal respiratory distress. And if you get any of these problems or issues, then of course you're going to have increased poor outcomes. But since pregnancy-related outcomes are correlated with severity of underlying maternal liver disease, it's obviously going to be critical to stratify your patients according to the risk, and that will help you to better plan a good outcome in pregnancy. And I think if we're looking for a magic number here, if you've got a MELD score of less than 6 pre-conception, then pretty much all of the data would support the woman having a likely excellent pregnancy outcome. Whilst if you've got a MELD score of 10 or more, then that's more likely to predict the development of decompensation. So, and of course, anything in between will be somewhere in the middle. So in terms of looking at some of the specific guidelines within, and in terms of counselling, I think the first point I want to make is that in any lady with cirrhosis, plus or minus portal hypertension, who's considering pregnancy, it's so important to undertake pre-pregnancy counselling and to think of all these things ahead if you can, to pre-plan. And I think it's important to do some sort of risk score, and I think MELD score is possibly the easiest one. And certainly in the guidelines, our EASL guidelines, we recommend doing a MELD score, but you can also do an ALBI score or an APRI score. And really, the bottom line is low MELD scores, you're less likely to need to do screening, particularly for varices during the pregnancy, whereas obviously higher MELD scores, it's going to be critical that you do screen for varices, and ideally in the year before the pregnancy is planned rather than doing it afterwards. And when we think specifically about esophageal varices, variceal bleeding is still significant in women with cirrhosis who are pregnant, and it can be reported in up to a third of pregnant women and up to 50% with kind of non-cirrhotic portal hypertension as well. And of course, it's associated with significant mortality if there is bleeding, although recent studies have suggested that perhaps is a lot lower now than it used to be. For women with non-cirrhotic portal hypertension, so we're talking about those people, for example, with portal vein thrombosis or splanchnic thrombosis, although variceal hemorrhage can occur during pregnancy, the mortality is generally lower than patients who have cirrhotic portal hypertension, and that's probably because there's less likely to be liver synthetic dysfunction accompanying the portal hypertension. So in terms of managing esophageal varices in pregnancy, the first thing to say actually is endoscopy is very safe in pregnancy actually. So don't be afraid to do an endoscopy if you need to in the usual left lateral position. And it's absolutely fine to use a benzodiazepine like midazolam for sedation. And I think what's critical is actually knowing if your lady has actually got varices. So ideally this is best done before the planned pregnancy, but if not, it's definitely recommended to be done sort of in the second trimester onwards. In terms of thinking about managing variceal bleeding, so if we progress to, and hopefully this won't happen, but if you do have someone presenting with variceal bleeding in pregnancy, there are a number of things to be thinking about. Ideally, terlipressin is something to be avoided, and that's because it causes a vasoconstriction of the placenta, which can compromise the infant. It can also cause a spontaneous abortion and placental abruption. So what is safe to use is octreotide. And of course, as with any variceal bleed, you want to be thinking about using broad spectrum antibiotics, using endoscopic band ligation, which remains the gold standard. You could use glue or thrombin injection in life-threatening gastric variceal bleeding, and actually rarely TIPS can be done. And in the cases that I've been involved with uncontrolled variceal bleeding in pregnancy, TIPS actually led to a safe outcome. Just a few tips there. And in terms of thinking about other recommendations, if you have got somebody who's known to have varices during a pregnancy, it is absolutely fine to initiate and to continue beta blockers during pregnancy. The data support very, very little in the way of complications. And as I've already mentioned about screening endoscopy, and actually the sort of gold standard treatment, if you've got very large varices that look at risk of bleeding despite beta blockade, then variceal band ligation is entirely safe and can be done electively. In terms of delivering ladies with cirrhosis and portal hypertension, whilst I think it's often been thought that these ladies should go straight for a cesarean section, in actual fact, the data suggests that vaginal delivery is actually safer and associated with less complications. But what you need to do is plan these things and think potentially about an earlier delivery rather than letting ladies specifically go into spontaneous labour, perhaps at a more advanced stage. And certainly at King's, we generally plan induction of labour at sort of 36 or certainly under 37 weeks of pregnancy. If you are considering caesarean section, you've got to think about correcting coagulopathy and thrombocytopenia, and also thinking about has your patient got intra-abdominal and pelvic varices, and that's very, very important to consider, because obviously that can lead to tremendous bleeding. And in all cases, really, it's good to have a multidisciplinary discussion and to plan things well ahead. There is, of course, an increased risk of postpartum hemorrhage in any patient who's delivering and is cirrhotic. And postpartum hemorrhage probably occurs in about 5 up to 45% of women. And it can, of course, be due to a combination of factors, which includes coagulopathy, ectopic varices, particularly if they're in the pelvis, and thrombocytopenia. So now what I'm going to move on to speak about now is gestational liver diseases. And I'm going to start off by talking about preeclampsia and the sort of spectrum of HELLP syndrome, because this, of course, is the most common of all of the gestational liver diseases that you are likely to come across. And it is the leading cause of, unfortunately, maternal and perinatal morbidity and mortality worldwide. So this is really, really important that we get this right. And believe it or not, preeclampsia is still responsible for over 500,000 fetal and neonatal deaths and over 70,000 maternal deaths globally. So we really can do better here. And I think it's really important that we're thinking about this today. And of course, preeclampsia is defined as the onset of hypertension accompanied by significant proteinuria anytime after 20 weeks gestation. It's usually very rare to see this below 20 weeks. And we've got some very good internationally agreed definitions now. And the one that is proposed generally by the international guidelines is the International Society for the Study of Hypertension in Pregnancy, or the ISSHP definition. And I've just laid this out for you more for reference than anything, but really the definition of preeclampsia is a systolic blood pressure of greater or equal to 140 millimeters of mercury and a diastolic blood pressure of greater or equal to 90 millimeters of mercury. And that's usually on at least 2 occasions measured 4 hours apart. And it's important to say that this must be in somebody who's previously been normotensive as well, rather than actually it being part of somebody who's had hypertension throughout their pregnancy. And there's 3 cardinal features that are important to point out. That there must be proteinuria. There must be 30 or more grams per mole of protein, or a protein to creatinine ratio of greater than 300, or that's about 2+ on a urine dipstick. There must also be evidence of maternal end organ dysfunction, and that can really include any end organ dysfunction, including neurological complications, eclampsia itself, clonus, stroke, pulmonary edema, thrombocytopenia, DIC, acute kidney injury, and so on and so on. And it's very common actually for women to also present with abdominal pain, particularly epigastric pain in this context. And the third feature is uteroplacental dysfunction. And that can present as placental abruption or in an angiogenic imbalance of various clotting factors. And actually, there's a number of biomarkers that are currently being evaluated that may better define that. But also things like fetal growth retardation and intrauterine fetal death as well. And of course, at the other end of the spectrum, you've got mild preeclampsia, and at the other end of the spectrum, you've got the HELP syndrome itself, which is the most advanced form, which of course stands for hemolysis, H for hemolysis, E for elevated liver enzymes, which can frequently be up to 10 times the upper limit of normal, and of course low platelets. And as I mentioned, it's frequently accompanied by abdominal pain, particularly epigastric pain, and of course hypertension and proteinuria. And I think it's also really important to be aware that ladies with preeclampsia, and particularly in the more advanced forms, they're very vulnerable actually to developing spontaneous hepatic hemorrhage or rupture, which can accompany, can be associated with devastating mortality of up to 50%. And I actually put a picture of a CT scan of one of the patients that I was involved in managing with a spontaneous rupture in the context of developing preeclampsia. And the HELP syndrome is thankfully a lot rarer at the other end of the spectrum, and probably affects more like 0.5 to 0.9% of pregnancies, which is about 10 to 20% of all those with the more severe form of preeclampsia. And it's genuinely accepted that preeclampsia, particularly early onset disease, results in impaired impaired placentation in early gestation. And it's interesting that both preeclampsia and the HELP syndrome do share histopathological and placental features that may suggest this is part of a spectrum, and there may actually be changes in gene expression in both conditions that are shared. But the other thing that can be sometimes a little bit complex, and I'm going to cover this in a moment, is that the HELP syndrome may actually be sometimes difficult to distinguish from acute fatty liver of pregnancy, and there can be a little bit of overlap. But thinking just a little bit more about preeclampsia and the management of HELP syndrome, particularly in the context of liver derangement, there's this nice figure that I've taken from the EASL guideline, which kind of takes you through 4 steps in the management. So, of course, the first step is in identification. So it's about being aware that you're measuring blood pressure, you're doing a good clinical assessment, and you're measuring for proteinuria with urine analysis, and you're doing your baseline blood blood tests, but particularly checking for the transaminases and renal function. And actually, it's not written in this guideline, but I also do a lactate level as well. I find that's very helpful. The higher the lactate level, the more significant the liver injury and the worse the outcome. And it's of course important to do fetal assessments at the same time in terms of looking at Dopplers, and if this is something that's been going on for a more prolonged period of time, over a couple of weeks or so, fetal growth is also really, really important to look at, and to be aware that that baby could be small for dates. In terms of monitoring, it's critical that you take this very seriously, and that these ladies are admitted to hospital and really watched very, very carefully, because they can deteriorate very, very quickly. But you know, it's about doing those simple things. And I also frequently also look at a uric acid level, as well as a lactate, as I mentioned, as well as the basic biochemistry. And then in terms of stabilizing these people, obviously it's really, really important to treat the blood pressure, and that can be done with labetalol or nifedipine or methyl dopa, depending on the experience of the unit. And our obstetric colleagues are great experts at helping us to understand how to do this effectively. And of course, if people are very hypertensive, hospitalizing them is important, and considering giving magnesium sulfate as well, and that's of course part of most of the obstetric guidelines. And it's thinking about the gestational age. So if your a pregnant lady presents before 34 weeks gestation, then of course you may need to give steroids to promote fetal lung maturation. And potentially also the earlier that the lady presents, magnesium sulfate may actually be more relevant. And of course, we've talked about delivery, and the most important point here is that if your lady has got significant preeclampsia, you need to deliver them promptly, because that is the only way that things will improve. But to bear in mind that women can actually deteriorate post-delivery before they start to get better. But expedited delivery is really, really important in optimizing outcomes. In terms of other things and specifics, I've just put a couple of comments here on aspirin, and this is particularly for women, because of course many of us now will manage ladies who aren't just in their first pregnancy, they may be having their second or third, and if they've previously had a history of HELLP syndrome, then we know that aspirin can be very effective in preventing recurrence in a subsequent pregnancy, and a dose of about 150 milligrams from 16 weeks gestation or over is recommended until the 36th week of gestation. You've got to be careful to stop aspirin at the end, particularly if you're imminently going to deliver, because that will increase the risk of postpartum hemorrhage. And there's also some reasonable data to suggest that actually increasing, giving calcium replacement and topping up calcium stores may actually also reduce the later onset of preeclampsia. So I'm going to move on to now acute fatty liver of pregnancy. And of course, this is related actually in many ways to a condition that used to be seen. We don't see it these days, but you know, sort of 20 years ago, you frequently see children presenting with Ray's syndrome. And there's a very, there's shared pathology here in that it's a disorder of mitochondrial beta oxidation. It's a mitochondrial cytopathy. Unfortunately, it occurs very rarely, in about 1 to 10,000 or 1 to 20,000 births. And what basically happens is that you get microvesicular fatty infiltration of the hepatocytes, usually in the second half of the pregnancy, or usually more often in the third trimester. But it does have a significant mortality rate, usually up to 20%. And it's important also to remember that infants born to mothers with acute fatty liver pregnancy may have defects in fatty acid beta oxidation, and may be deficient in the long chain 3-hydroxyalkyl coenzyme dehydrogenase, or LCHAD as we know it for short. And it's important that actually these babies and mums are followed up and referred to geneticists to make sure that these things are followed up appropriately as they develop in childhood. But I mentioned that there are a lot of overlaps between the PET and HELLP syndrome and acute fatty liver pregnancy, and that I've put up a table here that show you some of the features that are shared and the features that are contrasting. In terms of hypertension, it's more prominent to see hypertension in preeclampsia and HELP than it is in acute fatty liver pregnancy. So if you're seeing predominantly hypertension, it's probably more likely to be on the HELP side of the spectrum. Polyuria and polydipsia, however, is a sort of cardinal sign of acute fatty liver pregnancy. And, you know, if that is particularly an issue and you've got a lady who's not diabetic, of course, then think more about acute fatty liver pregnancy. Hyperbilirubinemia and hypoglycemia are also more likely to develop in acute fatty liver pregnancy because you effectively have organs that are turning and being infiltrated with fat. So you're more likely to also see acidosis from the mitochondrial cytopathy and acute kidney injury and organ dysfunction. But it can be difficult to differentiate these. There has been a highly cited retrospective single-centre study, actually from the UK, which included 52 women with acute fatty liver pregnancy, for which they developed something called the Swansea criteria or the Swansea score. And this score really predicts the increased risk or the likelihood of stillbirth and requirement for sort of escalated treatment with plasmapheresis and risk of postpartum hemorrhage. And you can see that these criteria in this table here, and basically if you have 6 or more of these criteria, not only are you more likely to have acute fatty liver pregnancy, but you're more likely to have a poor outcome. So look at those: vomiting, abdominal pain, polyuria and polydipsia, as I mentioned, encephalopathy, hyperbilirubinemia, hypoglycemia, uric acid levels being high, ammonia being high, and so on and so on. So just have a look at those, and those are really quite well validated now. In terms of if you make a diagnosis of acute fatty liver pregnancy, particularly if you do have that a score of 6 or more of the Swansea criteria, then really you need to be thinking about admitting your patient to a high dependency on intensive care environment, because they will get very sick very quickly. They're highly likely to develop encephalopathy, elevated serum lactate, and renal dysfunction, and they may require hemofiltration and potentially even plasmapheresis. As with the preeclampsia and HELP syndrome, delivery should be expedited once the coagulopathy and metabolic derangements have been treated and you've stabilised your patient. And of course, this has got to be a multidisciplinary decision, again, with obstetricians and hepatologists. But there's actually very little data to support using anything like N-acetylcysteine. So generally, whilst people have used this frequently for this condition, there's no real data to support that. But there are small case series that suggests that plasma exchange may be very effective in improving not only maternal but also neonatal outcomes. And of course, there may be a small subset of women who continue to deteriorate and develop fulminant hepatic failure, and you may need to think about transplantation. But generally, unfortunately, this is very rare. I'm lastly going to cover intrahepatic cholestasis of pregnancy as the third main group of gestational liver disease. And of course, intrahepatic cholestasis is actually very common and is characterized by pruritus in pregnancy, elevated serum ALT and serum bile acid concentrations, and of course, the exclusion of other causes of liver dysfunction or itching. And intrahepatic cholestasis of pregnancy, or ICP, is confirmed when serum liver tests generally normalize after delivery. So this is again a condition that generally is reversible. It's commonest actually interestingly in Latin America. So in people from Andean nation, indigenous populations, the rate can be as high as 4%. It's also quite high in Asian origin, and it's lowest probably in European women at about 0.7%. And about 25% of women who are affected by intrahepatic cholestasis of pregnancy usually have a heterozygous mutation in one of the biliary transporters coded by ABCB4 or ABCB11 or ATP8B1. And a smaller proportion might have mutations in other genes implicated in cholestasis. But it's interesting that when you do a cholestasis gene panel, sometimes you get a number of heterozygote mutations, some of which are associated with pathology and some not. So you do generally need to get advice and to look at various databases to see if that can be helpful. In terms of thinking about gestational cholestasis, of course, bear in mind that it could also be associated with an undiagnosed autoimmune or cholestatic liver disease. And it's not unusual for women actually during pregnancy to develop or to have a flare of autoimmune hepatitis particularly. And you may also see this in patients with hepatitis C who are positive, although fortunately there are less and less of these now that we are much better at diagnosing this before women are pregnant or in early pregnancy. And women with gestational cholestasis are an increased risk of also being diagnosed with other hepatobiliary disorders. And of course, it's worth bearing in mind that of course there's an impact of the reproductive hormones, the estrogen, the progesterone. It's going to drive and make ladies that are already have biochemical features of intrahepatic cholestasis of pregnancy to be more susceptible and generally to present. And it's frequently seen in the third trimester, although you can see it as early as the first trimester, particularly in women with homozygous mutations. Now, hyperbilirubinemia generally affects about a third of women with intrahepatic cholestasis of pregnancy, but fortunately it's usually mild. But the thing that I think it's really, really important to focus on is rather than the bilirubin itself, it's actually to look at concentrations of bile acids and the transaminases, because these will continue to rise during gestation, and it's particularly the bile acids that help you to stratify risk going forwards, particularly to the fetus. Unfortunately, if you have got intrahepatic cholestasis, any biochemical derangement should usually resolve within 3 months of giving birth. But bear in mind that intrahepatic cholestasis of pregnancy is complicated by a number of adverse pregnancy outcomes, including stillbirth, preterm birth, meconium-stained amniotic fluid, and prolonged admissions to neonatal ICU. And the children of affected women have increased rates also of adiposity and dyslipidemia later in life, and that may be related partly to shared genetic mutations. So as I mentioned, serum bile acids are really, really important in terms of monitoring. And in women with confirmed intrahepatic cholestasis, I think it's mandated really that they should be measured at least weekly from 32 weeks gestation. And the reason why that's important is because when the bile acids go above 40 micromoles per litre or thereabouts, the risk increases significantly. And when the level goes above 100 micromoles per litre, then that risk is significant, and there's a high likelihood of spontaneous fetal death. So it's really, really important to monitor these early. This is a very complex figure, but this is a management algorithm for intrahepatic cholestasis. I've mentioned much of this already, but what this does really is helps to define in groups A, B, and C, defined mainly on an elevation of transaminases and bile acids as to the risk and how to take women from there. And of course, to highlight that group B is really those ladies with raised transaminases and bile acids of 40 or more, and that group C of more than 100. With those with the higher bile acids, we recommend treatment with urso, and I think I'm going to come on to that in a moment here on this slide, in that really you should be considering prescribing urso, which is very safe in pregnancy, although whether there actually is really good data to suggest it changes or has an impact on outcomes specifically for the neonate, it certainly helps with the pruritus and helps to reduce bile acids, and there's a multiple ways that urso has benefits. Whether we think about additional therapies, and what I'm thinking about here are things like rifampicin or cholestyramine or activated charcoal, the evidence is actually very weak here, and I think that this should be thought about on a case-by-case basis. There's also data now to suggest that IBAT inhibitors, those really expensive drugs that work on the bile salt export, can actually be used safely in pregnancy, but really there are very few numbers to assess that. But just think about risk in terms of the bile acids. Of course, you must involve a multidisciplinary team. It's good to talk about all of these patients with your obstetric team and your wider team, and to think about the things well ahead of delivery, and what needs to be thought about, and what needs to be followed up. So in summary here, I've put a slide, and I've actually taken this from the AASLD guideline, which actually has got a very helpful table here, where it does a sort of compare and contrast of intrahepatic cholestasis of pregnancy, HELP syndrome, and acute fatty liver of pregnancy, just to help you to compare and contrast what you might see in the condition. So I won't go through that now, but it's just a nice thing if you ever want to have a look, if there's any doubt, to help clarify things in your mind. And I'm going to finish now by thanking you for listening, and to remind you that we have got the 2 guidelines, and I know Norah's going to be talking more about this in a moment, that we would really encourage you to read and to engage with, to help you really manage these ladies effectively during pregnancy. So thank you for listening.
Thank you, Debbie, for this wonderful summary, touching to so many issues. So I think Norah is ready.
I'm ready, but I think we're not going to have me try to share the slides now. Is that right?
I think Kubilay will share for you. Kubilay Bey, beni duyabiliyor musunuz? Paylaşabilecek miyiz slaytları?
Evet hocam, şu an sesim geliyor mu acaba?
Evet, geliyor.
Tamamdır. Şu an ekranım paylaşılmakta mı acaba?
Evet.
Tamamdır. Hi again, Mrs. Norah. I'm going to help to your presentation.
Okay.
If you give me a next comment, I'm gonna give it this page.
Okay.
So.
And are you going to, you'll be controlling when they advance, or can I do that?
Yes, sir. Yes, ma'am.
Okay. All right. Perfect.
He will be controlling the slides, okay. So please say next.
Perfect. Okay, great. Well, I want to thank, first of all, Professor Shawcross for sort of setting the stage. And just to reiterate, both the AASLD and the EASL guidelines are actually quite similar. So that made it relatively easy for us to divide up the various topics. What I'm going to be addressing in my section is really the patient who already has chronic liver disease and how we manage those patients in the context of pregnancy. And for the most part, you'll see I reference a lot the AASLD, but I can assure you that the EASL guidelines are really very much mirror, or we mirror each other, I would say. In some instances, because the EASL guideline has been published more recently, they have a bit more updated information, and where that's relevant, I will be highlighting it. So next slide, please. Can you advance for me? Yeah, perfect. So just to highlight what I'll be discussing in the next 25-30 minutes is I'll go through viral hepatitis, the cholestatic liver diseases, autoimmune hepatitis, metabolic dysfunction associated to steatotic liver disease, alcohol, and then I'll finally touch on benign liver lesions. So if we go to the next slide, it's my disclosures, which are not relevant at all to this particular topic. So let's move on to the next, please. All right, so again, highlighting, as Debbie did as well, 2 excellent resources for you to utilize in terms of managing your patients with chronic liver disease. Next, please. So I just wanted to start by highlighting that for the patient who has chronic liver disease, we recognize that there's a lot of adaptations that occur during pregnancy that are going to influence. You already heard from Debbie about really the influence, particularly on things like portal hypertension, related to the blood volume increases that occur in pregnancy, particularly in the 3rd trimester. But the hormonal levels also change, and that's going to influence hepatic metabolism, synthesis, and excretory functions. We know that fibrinogen and clotting factors increase in pregnancy, so there is an increased risk of venous thromboembolic disease during pregnancy. And of course, there are also changes in bile. We know there's a higher risk, for example, of gallstones during pregnancy, et cetera. So all of these things are very normal in a pregnancy, but in a patient who has underlying chronic liver disease, these things may indeed affect the natural history of that chronic liver disease. Next, please. The point of this slide is just to say, we know that, again, normally in pregnancy, there are changes that are going to affect the interpretation of your liver tests. Alkaline phosphatase increase because of the contribution from placenta, because of the increased blood volume, albumin and hemoglobin decrease, and platelets to a certain extent. But the important thing to sort of say from this slide is that there isn't influence of pregnancy, of a normal pregnancy, on bilirubin, AST, and ALT. So if you see elevation of those, then that always warrants evaluation. So that's sort of the message from this slide. Okay, moving on, please. So I'll start out by just saying that the best scenario from the point of view of a hepatologist, and I think also for those that take care of women when they're pregnant, is that we think about pregnancy beforehand, and that we, as much as possible, try to plan the pregnancy. And that's really relevant for women with chronic liver disease. So in the context of our usual follow-up of women who have chronic liver diseases, we should, of course, always be talking about contraception in those that are of reproductive age, so that we are really planning a pregnancy when it's right for that woman. For some women and their underlying liver diseases, or based on their stage of disease, such as cirrhosis, we need to discuss fertility issues, and if that's going to be something that's going to be relevant in terms of how they think about conception. And then, we'll go through each of these liver diseases and we'll see the influence of pregnancy on the chronic liver disease, and vice versa, the chronic liver disease influencing the pregnancy. And then I think Debbie also highlighted knowing what happened with prior pregnancies can also be very helpful in terms of how we do our conception counseling. So these are all kind of the educational component for a woman who is considering pregnancy. And then sort of as we're moving to, okay, they want to become pregnant, how do we prepare that woman to be kind of have the optimal outcome? Here we want to get updated staging information. So we would use non-invasive testing, for example, elastography or others, to say, does this patient have cirrhosis or not? We want to think about the stability of their chronic liver disease and be sure that we have a stable scenario as they're thinking about conception. And then for some of the diseases that we are treating in terms of their chronic liver disease, we may need to make a medication adjustment to those that are safe during pregnancy. So all of this needs to happen before conception occurs in order to maximize good outcomes with pregnancy. And it's been stated before, and I'll just state it again, it comes through in both of the guidelines very clearly, is that these women are complex and that we need a multidisciplinary approach in order to have the very best of outcomes. And that means obstetricians, maternal fetal medicine, hepatology, and other experts sometimes to really ensure that this woman has sort of wraparound care to ensure good outcomes. Next. So I'm going to start out by talking about viral hepatitis, and here a lot of the focus is around how do we prevent mother-to-child transmission. Both hepatitis B and C can be transmitted from mother to child, so a lot of really prevention is focused on that. This slide is to convey that for both B and C, the period of risk is primarily in the perinatal period. While interpartum transmission can occur, that's usually related to either maternal placental dysfunction or procedures done during pregnancy, such as chorionic villus sampling, for example. Most of the risk, really the risk period, is peripartum, at the time of delivery. And so a lot of our focus in terms of prevention is what happens at the time of delivery. And just to state that postpartum transmission is extremely rare. We consider breastfeeding not to be an issue, but need to be mindful of things like cracked or bleeding nipples that might, in some rare instances, contribute. Next slide. So let's talk about hepatitis B first. In terms of the maternal risk, next please. The maternal risk here, what we think about in terms of when do we treat these women, and by treat here I'm talking about the antiviral therapy for hepatitis B. We would use the standard indications. If they have active elevated HBV DNA levels or elevated ALT levels, they have an indication for treatment, and that woman should be on treatment kind of regardless of whether she's pregnant or not. And we have other sort of standard indications. Women with advanced fibrosis should be on treatment, whether they're pregnant or not. And so these women, the standard indications, if they're on treatment, would continue their antiviral therapy during pregnancy. Next. But of course, there are issues specifically related to the mother-to-child transmission. So both guidelines are very strong in terms of recommending the use of antiviral therapy in women solely as a mechanism to prevent mother-to-child transmission. We know that the HPV DNA level in the mother at the time of delivery is a risk factor for transmission from mother to child, independent of vaccination and HPV administration. Next, please. And that level of HPV DNA is greater than 200,000. So we know if their viral level is under 200,000, there's negligible risk of transmission, but if it's over, then the risk goes up as shown in the figure on the right. So in those women, it's recommended they receive antiviral prophylaxis in the 3rd trimester. Next slide, please. So the way that this is kind of put together in the guidelines, and again, they're very consistent, is that you should be checking the HPV DNA level in the 2nd trimester and generally initiating antiviral. And this is in women who don't otherwise have an indication for antiviral therapy, and then starting them on antiviral therapy in weeks 26 to 28. Again, this is based on their viral level being over 200,000. You would use, in the guidelines, the recommendation is to use tenofovir DF, so TDF. But I have to say that I'm going to share with you that now the recommendations also say that you can use TAF or tenofovir alafenamide as well. Both of those are safe in pregnancy. So in somebody who has a high viral load over 200,000, you would start that antiviral therapy in weeks 28 to 32, and then continue it up until the time of delivery, up to as long as 3 months postpartum. So that's this algorithm. In women that have lower viral loads, there is no indication for using antiviral therapy specifically in the context of pregnancy because the risk of transmission is very low if their viral levels are under 200,000. Next. I just wanted to highlight, though, that there's been a very important study just published that neither of the guidelines really speak to, but I want to make you aware of. And this was a study in which they actually were focused on settings in which HBIG is less available. So in countries where getting access to HBIG is very limited, so they only have vaccination of the infant available. And what they did in this study is they started the TAF or TDF at week 16, so much earlier in pregnancy, in women who had viral loads over 200,000, and showed that in using a longer duration of therapy in combination with a vaccine, that they had non-inferior outcomes compared to starting it later and using vaccine plus HBIG. So the message here, I think, is that the therapy around prevention of mother-to-child transmission is evolving, and in regions of the world where HBIG is not available, then this study would suggest starting the TDF and TAF earlier adds benefit in terms of reducing the risk of mother-to-child transmission. Next. So this is just to highlight the drugs that are available for treating hepatitis B and what the guidelines are recommending in terms of what drugs to use. TDF or tenofovir disoproxil fumarate, that was the drug that was recommended in both guidelines. But now there's new information that says that TAF is also safe in pregnancy. So either of those drugs could be chosen if you, and you would start them typically, as I said, unless they have otherwise an indication, start them in the 3rd trimester typically and continue until the time of delivery. And just to make note that lamivudine and talbivudine actually are safe in pregnancy, but due to risk for resistance, we don't recommend those drugs. And entecavir, which is a very widely used antiviral, this is the one in which we don't recommend it in pregnancy. So if you have a woman who is planning pregnancy and is on entecavir, we would switch them to TDF or TAF. Next, please. So just one comment about like ALT changes that occur during pregnancy and postpartum in women with hepatitis B. So they've looked at the risk for ALT flares. This is for women that are not on HPV therapy. And what you can see is that they're very rare. So it's not a major concern. And when you look at when the flares occur, the most common is when you stop the antivirals. So, I just finished reviewing with you, you're going to start the antivirals to prevent mother-to-child transmission. You're going to stop them either at delivery or within the first 3 months postpartum. And then typically after that, you may see a flare. Indeed, it's been described in about 17% of patients that occurs, so maybe 1 in 5, but they're usually mild and you don't need to intervene with treatment. You can usually just follow these individuals and they'll resolve spontaneously. But the message here is that you can see postpartum flares, so monitor for them and just be aware that you may indeed have to restart antiviral therapy if the flares are severe. Next. Now I'm going to move on to hepatitis. So just to summarize, hepatitis B, all women should be screened. All infants should be provided HBV vaccination. Antiviral therapy is TDF and TAF. And the recommendations are around starting it for those that have viral loads over 200,000. You can stop the antiviral if you're using it just for mother-to-child transmission prevention at the time of delivery or up to 3 months after. I personally stop it at delivery. And then ALT flares can occur, so monitor for them, but they're very infrequently an issue from the point of view of severe flares. Okay, next. Let's move on to hepatitis C. So next, first the risks in terms of the mother. So you heard about this already from Professor Shawcross, that actually hepatitis C is recognized as a risk factor for intrahepatic cholestasis of pregnancy, so just be aware of that. Similar to hepatitis B, all women that are pregnant are recommended now to be screened for hepatitis C as well. Next. And in terms of the risk to the baby, there is a small risk of mother-to-child transmission. It's actually less than in hepatitis B, but about 5% of babies become infected in the perinatal period. And if the woman has HIV as well, that risk goes up to about 10%. It's only women that are viremic. But unlike hepatitis B, we don't have a viral load threshold specifically that has been associated with risk. Next. Now, the difference here, in contrast to hepatitis B, where we have antivirals that are safe and recommended for use in pregnancy, currently the antivirals for treating hepatitis C, the direct-acting antivirals, are not specifically approved for use in pregnancy, but as I'll share with you, our thinking about how to use them in the context of pregnancy is evolving. Next, please. So what are the sort of main concerns around the risk of mother-to-child transmission for hepatitis C? So if we don't have antivirals to use, what else can we do to minimize the risk of mother-to-child transmission? Well, that's shown in the figure here. We want to minimize perinatal testing. If possible, use non-invasive methods when possible. We want to minimize internal fetal monitoring. And it's recommended that if there's prolonged rupture of membranes, that's a risk as well. So just managing the pregnancy, the time of delivery is very key. And our obstetricians generally are very aware of these potential risks. One thing to note is that C-section versus vaginal delivery has not been associated with a decrement in the risk of mother-to-child transmission. And similarly, breastfeeding is not a risk. Next. And then what happens in terms of the pregnancy itself? What happens to the viral levels during pregnancy? As shown in the figure on the left, they bounce around a bit, but they don't really change very much. But one of the very interesting phenomena around pregnancy and hepatitis C is that there's been well-described spontaneous clearance of hepatitis B in the postpartum period. And it's been described in up to 25% of women. So the message here is that if you have a woman who has hepatitis C and is going through pregnancy, and then after pregnancy, you're thinking about starting them on treatment, it's important that you recheck their HCV RNA, because there's a possibility that they may have spontaneously cleared the infection themselves. Next. So the sort of changing thinking around antivirals in pregnancy is being influenced by studies that are being done. This is data recently presented at the AASLD TLM meeting. There's a prospective study using sofosbuvir and valpattosvir for hepatitis C during pregnancy. This is an ongoing study, and they are continuing to update the results. In this study, what they're doing is starting sofosbuvir valpattosvir in sort of second to third trimester, between weeks 20 and 30 gestation. They're showing thus far in the women that have been treated that they have not seen any adverse effects on the fetus or the babies. And what they have seen is the viral loads, of course, go down, and they've so far seen no cases of mother-to-child transmission. So these are the data that are starting to reassure us that potentially antivirals may be an option for us to consider in the future. Next. So to summarize the approach to women with hepatitis C in pregnancy, again, all women should be screened. The mother-to-child transmission rate is low, but can be reduced by optimal obstetric management. And so that's, of course, key to make women aware of. And their obstetricians are usually very on top of this. Antiviral therapies with DAAs, although they're not approved, the drugs themselves are not approved for use in pregnancy. This is where the EASL guideline is the more advanced version of how we think about this. in that it says that antiviral therapy with DAAs can be considered during pregnancy, but you have to have a thorough discussion of risk and benefits of treatment. I will note that sofosbuvir, valcadosphere, for example, and glecaprevir, propentasvir, that there's no known teratogenic effects of those drugs. And so, I think that that's helping to inform guidelines about how we think about the antivirals. And then, of course, breastfeeding not contraindicated, although generally not recommended during antiviral therapy. Again, a risk-benefit discussion is needed. And because of this risk of mother-to-child transmission in viremic moms, it's important that we follow up the babies to find out if they're infected and whether they themselves need treatment. Next. Now, moving on to MASLD. So I think metabolic dysfunction-associated steatotic liver disease is probably the most common disease we may see among our pregnant women. Next. In studies that have been done, next please. Thanks. In studies that have been done, I think the data are still not really well established, but somewhere around maybe 1 in 5, 1 in 4 women may have steatotic liver disease. Typically it's mild and not of severe, but there can be cases of women who have MASH, who have the steatohepatitis, and even have more advanced fibrosis. So important to consider the impact of that on the women's pregnancy. Pregnancy itself is associated with specific metabolic changes that are necessary for promoting fetal growth and development that really can overlay those that we see in patients who have MASLD. We get an increase in adipose tissue, decreased insulin sensitivity, increased lipolysis. That's all part and parcel of what's necessary for fetal growth. And these changes can negatively impact both the intra and sort of subsequent metabolic risks for women with MASLD. So a really kind of interesting, I think, quite complex disease to manage during pregnancy. Next, please. And there have been now studies looking at whether women who have MASLD are at increased risk for adverse pregnancy outcomes. This is one of the larger studies and highlights the increased risk. They're primarily maternal risks, being increased risk for hypertensive complications, postpartum hemorrhage. And I would say the maternal death, I would just say, is very wide confidence interval. So just have some reservations about that. But in terms of perinatal outcomes, the main risk of us is a preterm labor and really not other perinatal outcomes that have been identified in women with MASLD. Next. And there's some interesting, I think, emerging and really relevant data around what happens to the fetus and to the baby in women with MASLD may influence the baby's outcomes in the long term. And that's related to sort of fetal programming that occurs that ultimately sets up those babies and children to get higher rates of obesity, metabolic syndrome, and MASLD themselves. So in speaking with women around the importance of managing their metabolic conditions during pregnancy, it's relevant to highlight that what they're doing for themselves will also be beneficial from the point of view of their babies as well. Next. Breastfeeding here is really a relevant conversation to have with patients because there are clearly studies that show that breastfeeding is beneficial in women with MASLD, both in terms of their own risk for future progressive MASLD disease or MASH. So women who breastfeed have lower likelihood of having progressive disease. And that's based on the study I show on the right, where those that have lactation greater than 6 months have a lower odds of having MASLD in the future, but also it improves their own metabolic profiles postpartum. And so that's why we, in fact, encourage women to consider breastfeeding. Next. And so the summary of recommendations for women with MASLD is to do really importance of preconception counseling and discussing the benefits of optimizing the weight and metabolic comorbidities before they conceive, remembering that that environment then helps their fetus and baby from the point of view both during pregnancy and postpartum. Pregnancy can exacerbate the metabolic comorbidities, and so we have to be aware of that. It needs active management. And at least in the AASLD guidance, we also included information around optimal gestational weight gain, which is different in women who are overweight or obese at the time they conceive. So being aware of that and counseling women around appropriate weight gain during pregnancy is important. And then, of course, breastfeeding encouraged because of its metabolic benefits. Next. Now, I just have one slide on alcohol-associated liver disease. I think it's not a difficult concept to say that alcohol during pregnancy is something that's really needs to be avoided, but obviously women who have alcohol use disorder and alcohol-associated liver disease do become pregnant. And what's interesting is there's now data showing that women of reproductive age are actually drinking more now than they did 10, 20 years ago. So this is something we need to be aware of. And so studies have shown that really women of younger age are drinking more, binge drinking, daily alcohol use. So it's something that really needs to be considered. Shown in the blue box are the known effects of alcohol on pregnancy outcomes. They are not good. They have reduced fertility rates, higher rates of preterm birth, and low birth weight, and probably the most serious, of course, being the fetal alcohol syndrome. Next. So the recommendations in both the AASLD and EASL guidance is around the importance of screening women for alcohol use. So every pregnant woman should be screened for alcohol use, referred for management of alcohol use disorder as appropriate. If you have a woman who has alcohol use disorder, counseling them to delay their pregnancy until abstinence is achieved would be highly valuable. And then there's comments around the use of medications. So we know that there are medications that can help individuals with alcohol use disorder to decrease cravings and help them in achieving abstinence. So just in terms of the approved drugs for treatment of alcohol use disorder, disulfiram is contraindicated in pregnancy, but naltrexone and acamprosate can be considered. Again, it's a risk-benefit discussion to be had with the patient, but to have that discussion to help facilitate women achieving abstinence from alcohol. Next. I'm going to sort of in the focus now on cholestatic liver diseases, first PBC and then PSC, but there's a lot of similarities between these two cholestatic diseases. So shown on the left is first, how does PBC affect maternal outcomes? The data suggests there's really no impact on fertility that's been identified. Interestingly, 1 in 3 new diagnoses of PBC are said to occur in pregnancy. So to realize that you might make the diagnosis, and it's typically because the women present with pruritus, and then that pruritus leads to an evaluation, and in some cases leads to a diagnosis of PBC. As shown in the figure on the right, pruritus tends to increase during pregnancy. So women who have PBC will have a worsening of their pruritus in about 50% of women. That's the case. And in terms of biochemical flares related to PBC, those are greater in the postpartum period, as shown in the far set of bars. And then in terms of fetal outcomes, here we see also a higher rate of preterm delivery. Next slide. For PSC, in terms of looking at sort of the what happens to women during pregnancy. So about 1 in 4 will develop some symptoms that really are related to their PSC during pregnancy. It can be a little tricky in these women because oftentimes their bile acids can be elevated at baseline. So making a clinical diagnosis of intrahepatic cholestasis of pregnancy in women with cholestatic liver disease can be very challenging. And for that reason, it's typically recommended that cholestatic liver disease patients have a baseline bile acid done, so you can sort of use it as a baseline during pregnancy to facilitate making the diagnosis of ICP. Worsening pruritus, new pruritus is quite common. Cholangitis, of course, a risk in patients with PSC is relatively infrequent, but does occur. And in terms of the pregnancy outcomes, they're shown on the right. There's higher rates of preterm birth, higher need for C-section. And since a lot of these women often have IBD, I find that often I'm co-managing them with their IBD specialist, and especially a lot of them are on immune modulatory therapy. So, but independent of their IBD, there is higher rates of preterm births related to underlying PSC as well. Next slide. So to summarize the approach to both PSC, the cholestatic liver diseases, as I highlighted, because they often have elevated bile acids at baseline, it's recommended that you obtain their total serum bile acids in the first trimester as a way to help you in excluding ICP if and when it occurs with worsening pruritus during pregnancy. UDCA, so URSA, which is a recommended first-line therapy for PBC, and also some PSC patients are on it. That's a safe drug, so that's really one that should be continued during pregnancy without interruption. They can develop vitamin K deficiency because it's one of the fat-soluble vitamins, so correct it as needed. Monitor the INR regularly. The IBD specialists are usually the best to advise around the safety of the immunomodulatory therapies in patients who have concurrent IBD and PSC. And then if you do need to image patients because you're concerned, for example, about stones or a complication of PSC, ultrasound or MRI would be the recommended imaging studies of choice. And then finally, just to mention that there is a potential for postpartum deterioration in their liver disease. I highlighted you that you can get these biochemical flares, so don't forget to monitor them, not only during pregnancy, but maybe with increased frequency in the postpartum period as well. Next. So this is just a quick summary of the cholestatic liver disease medications that we use. I already highlighted to you that UDCA is compatible and safe in pregnancy, but obeticholic acid is not recommended due to a lack of information on safety. Fibrates, interestingly, AASLD actually says not to use due to lack of safety data. EASL suggests that you may consider it after the first trimester, but need to have a careful consideration of risks and benefits. Of course, there's 2 new drugs that have been approved for the treatment of PBC very recently. We currently do not have any safety data around those drugs in pregnancy. Cholestyramine and rifampin would be the drugs of choice for treating the pruritus, and antihistamines can be used as well, as all of these are quite safe during pregnancy. All right, next. Autoimmune liver disease is the last of the chronic liver diseases I'll review. So just to highlight in this figure, what are the consequences of having autoimmune disease, autoimmune hepatitis in pregnancy? So this was based on a large US study of women who had autoimmune disease, comparing those with and without chronic liver disease in terms of the outcomes. And what they showed, as shown in the middle, is that autoimmune hepatitis in pregnancy increases the risk of preeclampsia, eclampsia and HELLP syndrome, of gestational diabetes, and of preterm births. But there's no increased risk of postpartum hemorrhage and no increased risk of maternal or perinatal deaths. Next. So there are data that suggest, as shown on the left, that fertility is reduced in women whose autoimmune hepatitis is poorly controlled. So the goal is always to kind of optimize their control of autoimmune hepatitis before pregnancy. Again, de novo autoimmune hepatitis, just like de novo PBC or any other liver disease, can occur during pregnancy. If you're trying to make the diagnosis of autoimmune hepatitis during pregnancy, you're going to use the same diagnostic tests and approach as you would in somebody who's not pregnant. And in terms of the flares, autoimmune flares, they've been described really anytime during pregnancy, including the postpartum period. And actually the first 3 months is thought to be the highest risk for having autoimmune flares, with about 25% of women experiencing flares during the first trimester. And what are the risks for getting flares during pregnancy? It's not being on treatment and having a shorter duration of remission before you conceive. Okay. And then finally shown on the right, just go to the right just for a second. Thank you. If you could just go back for 1 second. It was just to remind you about the medications, and really the message there is really that the medications we use to treat autoimmune hepatitis, which are corticosteroids, azathioprine, which are kind of cornerstones, those are safe during pregnancy. But the one really important drug to be aware of is that mycophenolate mofetil, so MMF, is actually associated with teratogenicity and needs to be stopped before an individual conceives, and they should be off the drug for at least 3 months before they conceive. So just to kind of summarize the management of autoimmune disease in pregnancy, this is where preconception counseling is really important, because you want the woman to be on hopefully safe medications, meaning not on MMF, and have had a period of stability before they conceive, because that's going to have the best outcome during pregnancy. And at least in the AASLD guidelines, we actually have a recommendation that women delay conception for at least a year to ensure stability. If you're going to, once the woman becomes pregnant, you want to monitor them very frequently during pregnancy, at least every trimester, and I do it more often than that. And then, of course, recognize that they can have a flare postpartum, so continuing to monitor them postpartum is also important. Next. Sort of the last thing I just will touch on, and I'm really aware of the time, so I'll just say this very briefly, is that, you know, there are benign lesions in the liver that we frequently diagnose: hemangioma, nodular focal nodular hyperplasia, and adenomas. Only the hepatocellular adenomas are hormone sensitive and are really the ones that are the most concerned during pregnancy. But I do think that the EASL guidelines also highlighted an important aspect that is not in the AASLD guidance, and that's around hemangiomas. And there they recommend that if you have somebody who has hemangioma that's either a giant hemangioma, meaning over 4 centimeters, or is in an exophytic position, that those individuals are at higher risk for rupture, and that those individuals also need close monitoring. So I think that's an important addition to guidelines. If you could just go to the final slide. And this is around the management of patients with adenomas. And the message here is that individuals who have adenomas that are 5 centimeters or larger are at increased risk of bleeding, as highlighted the box on the far right. So these individuals need a treatment plan before they conceive, ideally. Either they undergo bland embolization or potentially resection. So that's really the important message here, is that if they have an adenoma of 5 centimeters or more, they need active treatment before conception. And then those that are under 5 centimeters need to be monitored for growth during pregnancy and the postpartum period, because they can have an increase, and then you may need to be actively treating. Okay, thank you. I have one more slide. It's just a summary. If you could just go to that, and then I'll just close. I just have really highlighted for you that really every single chronic liver disease needs active attention during pregnancy. But that with good preconception counseling and active management during pregnancy, we can actually get these women safely through and have good maternal and fetal outcomes. And of course, a multidisciplinary approach is critical for us to achieve that. Thanks very much.
Thank you, Norah. So, Dr. Deren, would you like to introduce Dr. Edip? You are muted.
Dr. Kerr is our second-year fellow in maternal fetal medicine at Hacettepe University, and he will share us with maternal fetal specialist view in terms of liver disease, perspective of maternal fetal medicine.
Are you seeing my presentation?
It's fine.
Yes.
Okay. Hi everyone from Turkey in Ankara, which is the capital city of Turkey. Firstly, thanks to my professor Yasemin Balaban and my mentor Professor Özgür Deren to give a chance presentation in this platform. I try to do the summarize in this subject as a maternal fetal medicine specialist in liver health and diseases in pregnancy. My job is very difficult now because before the speakers, Professor Norah and Debbie are really did impressive presentation, but I try to summarize that topics. In pregnancy, liver disease in intrahepatic cholestatic, acute fatty liver or pregnancy, acute viral hepatitis, chronic viral hepatitis, autoimmune hepatitis, Wilson disease, hemochromatosis, cirrhosis, portal hypertension, and esophageal varices, liver transplantations, cholelithiasis and cholecystitis and pancreatitis. I try to summarize them. We know that the hepatobiliary diseases in acute viral hepatitis is the most common cause of the jaundice in pregnant women, but we see that the similar to the general population. If we use in diagnosis on abdominal CT, the fetus is often under the one radiate. So if we do that, if indicated, we can do the abdominal CT to diagnose this situation. Intrahepatic cholestasis, we know that the cholestatic hepatitis and the icterus gravidarum in pregnancy, and 2% in this population. In Turkey, we know that 0.45% intrahepatic cholestasis and impaired canalicular transport of bile acids. We see that the main symptom is pruritus. It can be adding jaundice or not. It shouldn't be necessary. Due to cholestasis and bile salts deposit in the skin, and we have to diagnose this topic. Pruritus and fasting bile acids increase the 10 micromole/liter, and we know that more common in especially multiple pregnancies, and we can see the genetic predisposition, some genes, ABCB4, ABCB11, and ATP8B1 gene, maybe hepatocellular transport site system. It can see mutation in these genes. Conclusions, bile acids are not fully excreted, accumulate in the blood, and hyperbilirubinemia we can see, but however, total bilirubin under the 4 or 5 milligram /deciliter, and the ALP increases more than normal pregnant woman. Pay attention for this situation. ALP increases more than normal pregnant woman, and the hepatic transaminase is normal or slightly elevated, especially under the 250 U/L. In risk factors, we have to look at the advanced age, especially increasing in the 35 years, and multiple pregnancy. It's important for us. And the winter months, we can see the intrahepatic cholestasis is much more than the other months, and chronic hepatitis C, especially in the case of the HCV RNA plus. Vaginal progesterone using in preterm labor prophylaxis as a risk factor in this topic, and the use of the sex steroids, we can see the risk factor again. Improves postpartum and subsequent pregnancy, or again with E containing drugs, and the pruritus in late pregnancy, maybe rarely early time, and the generalized pruritus is more common on the soles of the hands and feet. Jaundice, maybe we can see, but it's rarely 10% pregnant. And to exclude the cholelithiasis and the biliary obstruction, hepatobiliary ultrasound is semi-normal generally. Serum transaminases levels are relatively low and excludes acute viral hepatitis in this situation. Normal liver parenchyma and normal liver anatomy in ultrasound, we are seeing that the liver biopsy is sees that the center lobular cholestasis, no inflammation, and necrosis C. 40-90% recurrence in the next pregnancy. Pay attention that the different from acute fatty liver for us, and the azathioprine may trigger the disease. It can be important. Ursodeoxycholic acid, the first choice, we know that, and it decreases the pruritus, and bile acids and hepatic transaminases in blood decreases again. The discharge of bile acids into the hepatobiliary system is increases, and we see the babies, the preterm labor, fetal distress, RDS, and need for neonatal intensive care unit decreasing because of the ursodeoxycholic acid using. Cholestyramine, the other drug, it acts on the enterohepatic loop, prevents reabsorption, the absorption of both bile acids and fat-soluble vitamins decreasing, and especially we pay attention the vitamin K deficiency attention and the other vitamins A, D, E, and the K because of the fetal coagulopathy and the associated ICH and the stillbirth case reports. Then antihistamines and topical emulsions we can give that the patient. Bile acids we have to look at the then under the 10 micromole/liter in normal pregnancy, we know that, and getting higher and higher as the value increases. Preterm labor, meconium stain, amnion, RDS, fetal distress, and stillbirth, especially the increasingly 40 micromole/liter, and the upper the 100 micromole/liter, poor outcomes, really higher increasingly. In intrahepatic cholestasis, labor induction and C-section increases, and under the 5 Apgar births increases again. We know that we didn't see any polyhydramnios situation in this disease. Perinatal mortality slightly increases in severe disease. Bile acids can be related with cardiac dysfunction. PR interval is prolonged on fetal ACG, and again the fetal death is more important for us. Preeclampsia and the GDM associated in new publications, but no eclampsia associated with this situation. Upper the 34 week, we suggest that the weekly examination with maternal fetal specialists and importantly birth at 37th week again. New topic is acute fatty liver of pregnancy, the most common cause of acute liver failure in pregnant women. We know that, and it's a microvesicular fat accumulation, and it's a paralysis of hepatocytes. We know that. The addingly mitochondrial dysfunction we can see, and we know mitochondrial protein enzyme complex mutations, the long chain 3-hydroxyachin CoA dehydrogenase enzymes mutations in chromosome 2. We can see this disease. Rare recurrence in the next pregnancy we see, and almost always starts in late pregnancy. Risk factors, as we looked at, the nulliparity, male fetus, and multiple pregnancies are the risk factors of this disease. Major complaint, persistent nausea and the vomiting. We can see fatigue, anorexia, epigastric pain, and progressive jaundice, and the hypertension, proteinuria, edema alone or in combination. In 50% of pregnant women, we can see the symptoms, but the difficult situation is clinic is similar to preeclampsia, so we have to difficult problems, some to separate these two diseases. Severe cases, we can see pulmonary edema and severe hemoconcentration and maternal acidosis, and then fetal death. Similar to this disease as a hypopotamus, because of the all of the things are hypo in this disease: hypocholesterolemia, hypofibrinogemia, hypoalbuminemia, and all factors are reduced, and the thrombocytopenia. This disease, just like the hypopotamus, this animal is enoughly wide and fatty, I think that. Variable degree of coagulopathy, life-threatening in operative delivery if severe. And hypoglycemia is frequently we can see, and the hepatocyte function blockage, and then gluconeogenesis is decreasingly, and the hepatic encephalopathy, renal failure, ascites, and the hyperechogenic appearance in the liver on ultrasound. Progressive worsening of the disease within hours. So really, we have to manage this disease so fastly to progressive worsening to prevent. Delaying childbirth. It's a maternal and fetal risk. Labor induction with MFM follow-up. In general, the fetus cannot tolerate labor. The vaginal delivery isn't contraindicated, but in generally, the fetus cannot tolerate labor. We see that the C-section can be performed to accelerate the hepatic recovery, and the maternal risks increases if coagulopathy is severe. As we see that the C-section birth is 90%, unfortunately. And hepatic dysfunction improves at 1 week postpartum after delivery, and the intensive medical support with adult intensive care units. Two special conditions that develop in the postpartum period. First of all, 25% diabetes insipidus, and the second one is acute pancreatitis. We know that. Causes of maternal mortality, as we looked at, the sepsis, bleeding, aspiration, renal failure, pancreatitis, and the gastrointestinal bleeding can be cause of maternal mortality. As we know that maternal mortality, preterm birth, and the perinatal mortality increasing highly in AFL of pregnancy. This table from our textbook, and if you pay attention the third line, you will see that in the fatty liver situation, hematologic and coagulation parameters are so loudly increasing or decreasing. The other ones, we didn't see any just like changes, but especially fatty liver, we are seeing that the hematologic and coagulation parameters changing very loudly. We can use the Swansea criteria for diagnosis. Upper the 6th criteria is significant, especially hypoglycemia, leukocytosis, and the high ACT and ALT level, high ammonia level, renal failure, and high bilirubin level, we can see. But in the Swansea criteria, we didn't see any LDH, albumin, or platelets. They aren't as a criteria of acute fatty liver of pregnancy. The other topic is acute viral hepatitis. There are at least 5 different types of acute viral hepatitis: HIV, HBV, HDV, and HCV and HE. Why the clinic is similar in all, especially, and the clinical infection, nausea, vomiting, headache, and weakness we can see, and 1 or 2 weeks before jaundice. The symptoms improve when jaundice develops, and the serum transaminase levels are not consistent with disease severity. Peak values between 400, 4000 U/L are reached when jaundice develops, but bilirubin typically increases despite a decrease in the transaminase levels, as we know that. What are the hospitalization indications? Persistent noise and vomiting, prolonged prothrombin time, decreased in albumin, hypoglycemia, high serum bilirubin, and CNS findings. We can hospitalize the patient. Mortality rates 0.1% with fulminant hepatic necrosis. Most deaths due to fulminant hepatic necrosis, similar to acute fatty liver. Half of fulminant disease cases are HBV hepatitis, and the hepatic encephalopathy develops. Mortality is so high, 80%, we can see. Chronic viral hepatitis, seropositive asymptomatic pregnant women, no problem during pregnancy generally, and in symptomatic chronic active hepatitis, pregnancy outcomes depend on the severity of fibrosis, in particular the presence of portal hypertension. We can see again in pregnancy, we know that the acute fatty liver most common reason is the acute fatty liver of pregnancy. The most common form of fulminant hepatitis reason is the acute hep B, and the liver cancer and the liver transplantation most common reason is generally chronic viral hepatitis. Shortly, we will see the hepatitis A. The HIV is not teratogenic and no perinatal transmission, as we know that. Preterm delivery and PROM can increase a little bit more, and neonatal cholestasis reported within Alagille syndrome. We can see the butterfly vertebra in CT. And even though HIV virus has been detected in breast milk, after a pregnant woman's exposure to hepatitis A, passive immunization with 0.02 milliliter / kilogram immunoglobulin, and the pregnant woman after an encounter with hepatitis A, single dose of HIV vaccine in 2 weeks as effective as immunoglobulin in preventing hepatitis A. Hepatitis B vertical transmission is from mother to fetus. We can see the responsible for at least 35-50% of chronic HBV infection. The main cause of transmission is breastfeeding, and we know that the transplacental viral transmission is so rarely we are seeing that. In countries with low prevalence, the main route of transmission is sexual or contaminated needles. It can be a reason that. And the transmission through any of the body fluids, blood is the most effective. Half of acute HBV fulminant hepatitis case, we can see again the HBV plus in pregnant women, preterm labor slightly increasing, and the reason of the highest maternal morbidity, the FGR or preeclampsia, doesn't increase. We know that, and as I said, that the transplacental viral infection is semi-rare. HBY DNA levels highest in pregnant women who have transmitted the virus to the fetus. If HBY immunoprophylaxis is not performed, HBs antigen plus is 10 or 20%, and the HBs antigen and the HBe antigen plus is 90% of transmission of the newborn, we will see. Neonatal immunoprophylaxis and the HBV vaccination prevents infections dramatically. 90%, we are seeing that our papers, and the immunoprophylaxis for pregnant women with high HBV viral load or HBe antigen. What are the drugs? Antiviral treatment should be given, and tenofovir, the first choice antiviral treatment agent in pregnancy. Lamivudine and telbivudine not recommended because of the barrier. Immediately after birth in a seropositive pregnancy, HB immunoglobulin and our HBY recombinant vaccine first dose, the total dose is 3, and the HBY positive mother can breastfeed. I know that the main transmission is the breastfeed and milk, but HBY positive mother can breastfeed. We know that the hepatitis B vaccine should be given to seronegative high-risk pregnant women, and the seroconversion nearly 95% after 3 doses. Hep D, chronic co-infection of Hep B and D generally, and the progresses more severely and rapidly than HBV alone, 75% in cirrhosis, and there is no neonatal transmission. We know that the HDY is a defective virus, but it can enter a cell infected with HBV. And the other virus is Hep C. Prenatal screening recommended for high-risk patients, not routine our clinic guidelines, but I know that the before speakers recommend that the Hep C screening is routinely. HIV plus hemodialysis recipients, IV drug using, born to a mother with HCY, and blood or organ transplantation before July in 1992, we have to screen this virus. Acute HCY infection is 80-90% becomes chronically, and the HCY diagnosis gold standard test is HCY RNA test. We know that most pregnant women have chronic diseases, so it will we look at the this topic just like this. In HCY infected pregnancy, we see that the FGR, fetal growth restriction, neonatal intensive care unit needs, preterm birth and mechanical ventilation need is higher increasingly, and the mother with viremi, adverse perinatal outcomes, and the vertical transmission of HCY infection to the fetus or infant more. We know that the invasive prenatal diagnostic procedures, just like the amniocentesis, chordocentesis, chorion-villus sampling, don't increase the chance of transmission to the fetus for us. So we can do this invasive tests safely. Prenatal transmission is 1/3 in peripartum period. HCY genotype, invasive prenatal diagnostic procedures, breastfeeding, or mode of delivery not associated with fetal and newborn transmission. It's important and to pay attention these topics, I think. And the internal fetal heart rate monitoring should be avoided. And the HCY plus mother can breastfeed her baby, not contraindicated again, and no vaccine to prevent it. Chronic HCV treatment, we see a true drug. The first of all is alpha interferon alone or in combination with ribavirin, but we know that the ribavirin teratogenic in pregnant women, so it's contraindicated. Hep E is probably the most common cause of acute hepatitis, more mortal in pregnant women. Fulminant hepatitis is rare, but more common and more mortal in pregnant women. It's important thing, I think. And the no vaccine, again, the placental transmission is very rare, we are seeing. Autoimmune hepatitis, often associated with autoimmune diseases such as autoimmune thyroid disease and the Sjogren's. Severe cases, adverse pregnancy outcomes get higher, and the preterm labor, FGR, and the diabetes mellitus frequency increasing again. The chance of preeclampsia or C-section doesn't increase in this case. Maternal and fetal complications are higher in pregnant women with cirrhosis. We can use azathioprine because of the prevents attacks and the improves prognosis. Safe in pregnancy and breastfeeding, azathioprine, we can use the drug. The Wilson's disease, we know that the copper excess and the chronic hepatitis and cirrhosis together. Pregnancy outcomes depend on the severity of the disease. Gestational hypertension and the preeclampsia increases in Wilson's disease. But maternal and neonatal outcomes are good as we see the preeclampsia in this disease. No bad outcomes as we see that we know the Kaiser-Fleischer ring in the eye and autosomal recessive mutation on the ATP7B gene, just like the intrahepatic cholestasis. Penicillamine, zinc, trientine, chelation therapy we can use, and it can be done during pregnancy. It's safety for in pregnancy. Hemochromatosis, it can cause chronic hepatitis and cirrhosis, maybe accompanied by diabetes mellitus, joint disorders, and the skin changes. Yeah, and the neonatal hemochromatosis, maternal autoantibodies in fetus, and the Iron hemostasis is impaired. Neonatal morbidity and mortality increases significantly. Again, the most important thing in this disease, I think. High risk of recurrence in the next pregnancy, and we can use antepartum IVIG may improve outcomes. Poor results in pregnant women, common complications, transient liver failure, varicose bleeding, preterm birth, FGR, and maternal death that we can see, and the esophageal varicose veins, poor prognosis criteria for us. Splenic arteria aneurysm is also seeming fatal. Pregnancy rupture in 20%, and the frequent third trimester rupture is 70%. Vaginal delivery is preferred in this disease, as we know that. Esophageal varices in pregnant women.
Edip, we are out of time. Edip, can you summarize a little bit? Okay.
Okay, Professor. I am fasting.
You can just pass over the topics that Dr. Norah and Debbie has mentioned already, right? Please.
Okay, shortly, I will tell the liver transplantation, and I am finishing my presentation. Liver transplantation, abortion in frequency doesn't increase, and the preterm birth is the most increased risk in pregnancy. Low birth weight, preeclampsia, and C-section increases again in this topic. And the pregnancy loss rate similar to the general population. The risk of the renal failure, hypoglycemia, inflammation, and the ARDS is also higher than the normal population. Rejection episodes 10% in pregnant women, and the pregnancy has no negative effect on the graft in liver transplantation. I'm passing the cholelithiasis and the cholecystitis and the pancreatitis, and that's finished. Thanks to again, Professor Yasemin Balaban and my mentor of Professor Dr. Özgür Deren to give a chance make a presentation this platform, and for the participants, thank you for your patience.
Thank you. Yes, Yasemin, you go ahead, please.
I would like to thank all the speakers. This is an extensive and huge topic. It's very difficult to cover, but you did great job. Thank you, Debbie, Norah, and Edip. There are a few questions. If Norah is with us, I would like to direct a few questions to her.
Sure.
Norah, one question is that what type of contraception we should offer to patient with focal liver lesions, benign lesions, especially during, the IVF, as you know, the hormonal loading of the patient. What do you think about it?
Well, just to re-emphasize, the hemangiomas and focal nodular hyperplasia are not viewed as being hormone sensitive. So for women that have those lesions, I don't have concerns about them in terms of whatever contraceptive they're going to use, or if they're going into IVF and they're needing hormonal therapy there, I really reassure them that those are not going to affect the size of the lesions or their risk. It's really the women with adenomas. And again, for contraception in women with adenomas, I advise them they could use IUD. That would be one option. They could use a progesterone-only form of contraception, and there's a lot of those available now, so I think that that's also safe. It's just to avoid the combination hormonal contraception is the one that I tell them to avoid. So that's my approach, and I think also sharing it often with the individuals who are prescribing, because I'm not usually the one prescribing the contraception. It's really to inform those that are around what the safety is for the various drugs that they may want to choose. And then for those that are going through IVF, so that's a little bit separate because often they do need to get very specific therapy. They're, I think kind of approaching it at the patients with adenoma similar to the way we think about them during pregnancy. And that is we would monitor those individuals for change in size. And obviously, if somebody is trying to become pregnant with IVF, you would have wanted to have a plan up front about that adenoma anyway. So if they had an adenoma that was more than 5 centimeters or greater in size, you should be pre-treating that and managing that before. If it's under 5, then I would just monitor it during the IVF, similarly to how I would do it during pregnancy.
Thank you. What about those patients after liver transplantation? Could you give a couple of hints for them?
Oh, sure. And I'm sure Debbie probably has a lot of experience with the transplant population as well. So similar, I mean, the first thing I would say is that it's important to talk about in women of reproductive age to be sure we're talking about contraception really from the moment they get transplanted. For many of those women, they will not have a return of their menses, maybe even for many months, but they're still potentially could get pregnant. So I think we want to have a plan around contraception right from the time that they get transplanted. And many of the comments I just said about choices of contraception are the same for post-transplant patients. I think IUD is fine, progesterone-only contraceptions are fine. So I don't have any concerns. We can come up with a mode of contraception for those women. I think it's a slightly different question to talk about your post-transplant patient who wants to become pregnant. And, you know, increasingly we have younger patients now, women of childbearing age who want to pursue pregnancy. My advice is, of course, I want them to have a period of stability before they conceive. You know, make sure they've not had a recent episode of rejection or some other post-transplant complication. We want stability. I'd want stability of their immunosuppressive drugs before they conceive. And in terms of the drugs that are safe during pregnancy, prednisone is fine, tacrolimus is fine, cyclosporin is fine. Those are safe. Azacitidine is also an option, although we don't use that very much in pregnancy. Of course, similar to in the autoimmune hepatitis realm, but in transplant maybe more so, they have to be off mycophenolate. You know, that's teratogenic. So they have to be off that for at least 6 months. And then there's not a lot of safety data around the mTOR inhibitors, sirolimus and everolimus. So I also recommend not conceiving if you're on those drugs as well. And I don't know, Debbie, if you want to add to that, but that's generally my approach in terms of the post-transplant patients.
You've echoed what I would have said. Yeah, and mycophenolate, I think, is really the one to just make people aware it should be avoided at all costs. Yeah.
Debbie, there are a few tough questions for you. First of all, what's your opinion on using uric acid level for differentiating HELLP syndrome from acute liver failure? Do you think it works?
I think it's difficult because uric acid levels, urate levels are raised in both. But actually uric acid levels rise increasingly as preeclampsia becomes more severe and as you go into a HELLP syndrome. But also uric acid levels are a good way of measuring how sick someone is. And of course, people with acute fatty liver pregnancy, particularly with mitochondrial injury, they also have elevated uric acid levels. So you can see it in both. I think probably much higher levels are seen, I think, certainly from my experience, in those with HELLP syndrome. And I know the obstetricians use uric acid a lot to help gauge severity, but you can see it in both. So I'm not sure it's reliable to look at an absolute level. I mean, I don't know what you think, Norah. Do you have an opinion on that?
You said it perfectly. It's useful if it's very high. Then the very high, I think, can support the diagnosis of acute fatty liver pregnancy. But I think that's the challenge is that they can both lead to elevation. So I don't think it helps, especially with early diagnosis. I think it's not so helpful in differentiating between those two entities.
I have my own question. The EASL guideline is very conservative on using ursodeoxycholic acid in intrahepatic cholestasis of pregnancy. Is there a reason behind that, since we are using it very liberally in Turkey?
Well, I must admit, I'm not an actual author of the EASL guidelines, so I wasn't part of that decision-making process. And I agree with you. I use ERSO a lot. I think it's very safe, and it really helps symptom-wise as well. So mothers really find it very helpful. So I do use it a lot. I guess with the EASL clinical practice guideline, they do try to make it very evidence-based. And of course, there's not studies out there directly comparing ERSO with placebo that you can actually say, well, look at this, because people will always err on trying anything that makes the mother feel better. So I think that's probably why they've erred on not being as supportive as they could. But to be honest, I use it a lot.
And one last question about the N-acetylcysteine doses in acute liver failure. Which dose do you recommend? The low dose or high dose as usually used in acute liver failure, pulmonary hepatitis?
So you're talking about in pregnancy-induced acute liver failure? Yeah. Oh, that's a good question, isn't it? I mean, we usually use the lower dose actually, which I know it as the 16-hour bag. You're going to ask me how many grams in that, but it's the 16-hour bag, the lower dose that we use generally at King's. Obviously, with paracetamol overdose, it might be slightly different, but I would use the lower dose. And what all that N-acetylcysteine does is it replenishes the glutathione stores in the liver, and it doesn't take a lot to replenish them actually, but it does. It's definitely helpful.
So I think this is all.
I think there are a few questions from Dr. Necati.
Okay, sorry, I missed it.
I would like to thank all the speakers for a great job. I have two questions actually. You said that chronic liver parenchymal diseases plus pregnancy patients may have a higher than 10 score of the MELT. Then possibly they will decompensate. It's okay. But if the patient had a surgical emergency, then is there any absolute contraindication for those patients?
I mean, I think you've got to take the situation. If your patient is acutely unwell and they've got a life-threatening surgical issue that needs addressing, I think you probably have to go for it, don't you? Whatever. It's just that I guess looking at a MELD score helps you to kind of put them in a risk category. But of course, anybody in that sort of situation, particularly if there is an emergency, a surgical emergency, are going to be at high risk of bleeding, high risk of developing infection, and high risk of having other decompensating complications. But in that sort of situation, you just get on and do it, or certainly we would, and sort of pray that it goes well. And I don't know what you think, Norah.
Yeah, I mean, I think everything is always about weighing the risk and benefit. And clearly when there's a surgical emergency, usually life is at stake, or there's something that's very serious. So of course you're willing to take more risk in that setting. So I think you just it has to be individualized. There's never an absolute, really. Well, there probably is, but it's a matter of weighing that risk and benefit for the individual. I don't think there's any other way to frame that. Okay.
Thank you very much. So my second question is, as you know, HPV guidelines due to the WHO was published in March in last year, Mm-hmm. So they have a recommendation that the HPV DNA levels, even you don't know HPV DNA levels, they just recommend to treat these patients without caring the HPV DNA levels. So what do you have a recommendation on this one?
Sure. I mean, I think that it's the WHO guidance is written for the globe, where there is variable access to HPV DNA testing, which in some countries can be more expensive than the drug. So the guidelines that were written by AASLD and EASL really are kind of more a reflection of, providing care in places where we have access to these tests. So if you don't have access to measuring HPV DNA or E antigen, then, I think if you have a pregnant woman, you would err on the side of treating, because you really want to minimize the chance of a complication during pregnancy, and in particular want to prevent mother-to-child transmission. The WHO does say that in areas of the world where they can't get access to HPV DNA testing, that use of E antigen can be a good surrogate for telling you whether the woman has high level of viremia. And the EASL guidelines also, say that if you don't have HPV DNA, use E antigen as the alternative. Either way, I think the safety of the antivirals, especially TDF and TAF, in the setting of pregnancy are such that if you're at all uncertain or don't have data, probably treating is the right strategy, because you want to minimize any chance that a baby becomes infected.
Thank you.
There is one comment in the chat box which needs clarification. According to our guidelines, those patients with hepatitis C and get pregnant, it's risky to make not amniocentesis but chordocentesis. So, according to our guidelines, amniocentesis is safe, but the chordocentesis is risky. Is it so, Norah?
So, there's not the data that informed this guideline is relatively modest. And it's based upon looking at studies in which they've looked at women who have transmitted to their babies and looking to see what their risk profiles look like, and shown that in some case, in women who have invasive procedures, there appears to be a greater frequency of mother-to-child transmission. The differentiation between amniocentesis versus CVS, I personally don't think there's enough data to sort of differentiate between those two. And both the AASLD guidance and EASL state that whenever possible, we should use non-invasive testing to try to arrive at, these answers. Again, it's always risk benefit, right? And then I think the other thing that the guidelines say is that it's really just a matter of informing women as well, right? So that they know that there's a small chance that there might be a interpartum transmission event. That's really part of it, is education, informing patients, and then doing the right thing to get the answer that you need. But at least I can say that AASLD and EASL are aligned in that they don't recommend invasive procedures unless absolutely necessary, and don't differentiate between amniocentesis and CVS.
Though it doesn't differentiate, but in CVS and chordocentesis, you have a direct penetration to the fetal circulation, right? So we usually look for the fetal, viral load is important. And the second thing, we prefer amniocentesis if we have to do any invasion procedures. But, to avoid is the best way.
Yeah. I think, when we don't have data, which is, I think, the case here, where we don't have a lot of data inform this, I think the rationale of why CVS would be more risky than amnio makes sense. But I think our goal always is to try to minimize the risk and just inform women of that potential. Yeah.
Yeah. Thank you.
And Norah, I think I should ask the question directed by Dr. Zeki Karasu. He is as you know, very important for all of us. He wants your comments on hepatitis D transmission to infants, babies. Is there a way to avoid it besides hepatitis B precautions?
So mother-to-child transmission we're referring to? Yes.
Yeah.
And I want to maybe I think this is where there also was some difference in terms of what I presented versus what Dr. Edip presented. And in that the AASLD and EASL guidelines do not view breastfeeding as a high risk for the baby. We don't view that as being the predominant time of risk. And part of that is because, of course, the baby gets HBIG and vaccination, so they're quite well protected. And so that's why we really promote breastfeeding as a benefit to the baby and not a risk from the point of view mother-to-child transmission. It's really the perinatal, it's the delivery that matters. And I think that if you provide the mother with antiviral therapy in the 3rd trimester, if you're able to do that, give the baby HBIG and vaccination within the first 24 hours, sooner is better, that really the likelihood of mother-to-child transmission is essentially 0. It's really highly effective. And given that you're preventing a chronic disease, it seems that's so valuable in terms of what we try to do in preventing that baby from becoming infected. But clearly there's circumstances where, the mother doesn't get antiviral therapy, for example, because they present late for delivery. And in those settings, the data suggests the sooner they get their HBIG and vaccination, the better. That's the best thing you can do to try to protect that baby. So instead of giving the HBIG and vaccination at 12 hours or 18 hours, you want to give it within the first 4 hours. And there was a very beautiful study actually in the New England Journal of Medicine that showed that if they got it within 4 hours, it was really highly effective in preventing. So if you can't get the mothers to get antiviral therapy, I'd say that's really important to do it very quickly after they're born. And then I think the other data that's becoming really interesting is that can we treat the mothers longer and maybe then have to be less dependent on the immunoprophylaxis we give to the infant. And the data there is suggesting that if the mothers are on therapy longer, then there's less need for HBIG, for example, right? So in situations where getting access to HBIG is limited or where the mother may not get access to vaccination, I think the mother being treated becomes really important. So we have a lot of things to offer to try to minimize mother-to-child transmission. The very best is we give it all, right? Treat the mom, give the baby HBIG and vaccination. So I hope I answered the question.
Thank you. So there is no extra thing to do for Delta patients. So
for Delta, I think if you treat B, you treat Delta, right? Yeah. There's no Delta if there's no surface antigen. And in fact, I haven't been able to find a case of Delta transmission from mother to child. If it exists, I've never seen it. And it's never been reported to my knowledge. But I think it's because if you prevent B, you automatically are preventing Delta. So I think our emphasis is on B. Do B, and then you're going to prevent Delta. And certainly in Turkey, you have more Delta than we have in the United States. So you may know more about this, but that's really the approach. Prevent B, then the Delta won't be an issue.
What I realized from this presentation is that the major difference in hepatitis B screening, since as a hepatologist, we are promoting the universal screening for hepatitis B and C in all the pregnant women all over the world, not only risk groups, but we promote the screening for all of them in each pregnancy.
Exactly. Yes. It's an important intervention, right?
Yeah. So thank you for joining us. Thank you for all these wonderful presentations. Also for the attendees, thank you for giving your time to listen to us. Dr. Deren, would you like to add something?
Thank you very much. It was a great pleasure for us to be with you. I hope we can have another webinar with our maternal fetal specialists. So we have a lot to learn from you. Thank you.
Thank you. Have a nice day.
Good night.
Night. Wherever you are. Have a nice year. Very beautiful year.
Yasemin, please, symbolic gift. I just remind you.
I should say that Dr. Necati Örmeci is so generous and donated a couple of trees for you as a speaker. So all world needs more tree, I think. We need more tree on the world. Thank you very much.
Thank you all.
That's very kind. Yes, thank you.